Thank you. Start again. Good evening, ladies and gentlemen, and welcome to this evening's meeting of the Health and Social Care Scrutiny Review Group. We go straight into the agenda. Item number 1, apologies for absence.
Chair, apologies from Councillors Ambia, Mahmood Hussain and Ayos, who's being substituted by Councillor Alia Khan.
Thank you. Minutes of the last meeting. Hope everyone's had a chance to read the minutes, and are those okay to be signed off? Thank you. Any disclosures of interest? Councillor Carr?
For agenda item number 1, it's personal but non-prejudicial. So yeah, that's my interest.
Thank you. Any urgent business?
None, Chair.
References from committees or other bodies?
Again, none, Chair.
Okay, I have nothing to report on since the last meeting. Okay, so item number 7, the Elft Luton Primary Care update. And who's doing this report?
Good evening, everyone. Just introduce myself. My name's Adil Ali Khan. I'm a local GP. I've been GP in Luton since 1992. I'm the lead GP at the Kingsway Health Centre and the clinical director for the Phoenix Sunrises primary care network as well. Recently, the contract for our surgery, as well as Birmingham, went out to procurement, and it was taken up and awarded to by ELFT, which stands for the East London Foundation Trust. Originally, it was set out as two separate procurements, but the commissioners decided that any practice less than 10,000 should be amalgamated. So this is why the two practices have been amalgamated. ELFT is an organisation which is clinically led, and it already has expertise in community health, mental health, and runs several practices within East London as well. It also has expertise in developing primary care deliveries for vulnerable people, homeless people, refugees as well. Looking at our practices, basically, even though we'll be amalgamated as one practice, Kingsway will be the main practice and Birmingham Park will be the branch practice. Birmingham Park have a weighted population of 6,400, whereas Kingsway, we have a weighted population of 10,400. The demographic of each practice is quite different. Kingsway have a 60% population of Asians, whereas Birmingham are mostly Caucasian. The demographic within Kingsway are on the 3rd deprived decile, whereas Birmingham is on the 4th as well. So delivery for healthcare services for both of these practices would be quite different, but I believe that it is very, very important for ELF to oversee and deliver on the primary care practices that they said they would be doing. Now, as I said, ELF have got expertise in delivering primary care services already, and what they have already stated is that they will look at our practice staff at the moment and they seek to develop them further, in that we already have a complement of GPs, advanced nurse practitioners, but what they also hope to do is to recruit clinical pharmacists, clinical technicians, paramedics as well. What they also want to do is to work very, very closely with the PCNs and with local services directly. One objective is to provide excellent primary care services and also address health inequalities within Luton. This can be done by a range of means. I think one most important way which this can be done is by looking at access. Access is one of the biggest problems that we have, not only in Luton, but nationally as well. Elft have come up with a range of strategies in order to help with access and work with the primary care network as well. Also, what they will also hope to be doing is working with the communities as well. And it's been very important for ELF to work and collaborate with the local communities. And this will take the form of reaching out with faith and community groups, targeting very specific groups within our communities, such as those with diabetes, heart disease, those with cancer and chronic conditions. Also, they're going to be looking at amplifying the voices which are silent at the moment, and those would be refugees, those would be the homeless as well, and also looking at people whose first language is not English, because very, very often what happens is that the people who cannot speak English often end up suffering from the health inequalities. What people don't understand is that the government's push the use of digital transformation quite a lot, but a lot of these community people in our communities do not have to use digital access. So this is a health inequality in itself. So I want to work with ELF in order to help outreach to these particular people in order to help them interact and access the facilities they require mostly. I think it's also going to be very, very, very important for ELF, and they've said they're quite prepared to do this, is to reach out to the communities and talk to various faith groups and various leaders within the communities to help patients and show them how they can access our health requirements that they require. One thing you will notice in Luton, that particularly amongst the ethnic minorities, the uptake of cancer screening is very low, and it's very, very important to go out into the communities and actually talk to leaders within the communities and members directly in order for them to realize that, look, these facilities are available, and it's very important that, and show them how important the use of these facilities are. I think ELF are very uniquely positioned in order to help Luton with this, because of their expertise in dealing with communities within Tower Hamlets, within Newham, and such places like Hackney. They're used to reaching out to such communities and breaking down barriers. And barriers is what we have at the moment, and it's very, very important that we have dialogue with the community, and we want to be all-encompassing, all-inclusive as well. As a clinical director myself, I see the importance of this, and ELF have said openly that they are very willing to work with the PCNs in order to help facilitate what we want to achieve in Luton as well. A lot of people will wonder how merging the two practices will work in essence. As I said, it will function on the outside as one list, but on a day-to-day basis, Kingsway will be the main practice, and Brammingham Park will be essentially a branch practice, but we will have oversight over both practices all the time. It is very, very important that we keep a close eye on all the parameters that are set out, and that it is very important that we look at the health and well-being of all that's involved within our practices as well. And I think it's very important to identify our priority actions, our strategic streams for the next couple of years. Elft have got the contract for, I think it's 4 years, 5 years, and that can be extended as well, depending on performance. But I've got every faith in that they will actually meet their marks. Most providers for primary care are profitable organizations, and the difference between Elft and other providers is that they are an NHS trust and they do not seek to gain profits. Any profits that they do accrue will be put back into the community as such. And I see this as a huge benefit from previous providers. In my dealings with Elf so far, they have been very upfront. They've been transparent. I've had dealings directly with the CEO and all the managers at all levels. They have been open, transparent, and they've also wanted to interact from a very, very early stage in the negotiations as well. And I really hope that their involvement in Luton will be a success, and hopefully will be an example to other primary care strategies all over England as well.
Thank you. Okay, I'll throw this open then. Any members would like to ask any questions? Councillor Nazir.
Thank you, Chair. Good evening, everybody. Yeah, I have seen what I'm interested about the homelessness you mentioned, that we do have problem because I closely work with a couple of homeless people, and they're not able to see the GP. Only they use the emergency A&E. So what sort of changes will be there for them? That's what I'm interested. And I wanted that answer first, and then I will go for that. Thank you.
If you're talking about the homeless specifically in the practice area for Birmingham Kingsway, is that your question specifically to that area? Okay.
So basically, Elft have developed outreach services in areas such as East London, and they have actually developed strategies which actually have been award-winning as well. So, as you know, this is very, very early. Elft have only just taken over on the 1st of October. So we have to sit down and we have to develop strategies for Luton per se. But that is something that is definitely on our radar, and we realise that is a problem. And as I said before, the homeless do not have open access in the way other people will do, such as access via telephone, maybe access via the internet or any digital means. So we have to be prepared. We have to be any strategies that we develop have to be very, very flexible as well. And it means talking to the community, seeing what we can do, and we have to be very, very flexible in our approach.
Yeah, thank you. But that's what we're actually looking for, something extra for the homelessness, because that's our homeless people are suffering because they don't have a address to, when they usually, when you say they don't have internet, yeah, I do agree that. Not only them, there are many people who still doesn't want to use internet, and we're struggling with other surgeries that, without, with the app and all these things, you can't make an appointment. So that's the other thing. If you would like, will we appreciate that if you look into that?
Just to give you an example of some of the work that we've done in London, for example, we have a refurbished bus that we've been using, for example, across 3 boroughs. So we offer homeless support and refugee support in Tower Hamlets, Newham, and Hackney. And in one of the boroughs, we have a refurbished bus where we have our clinicians going there. And we reach out to the community instead of them coming to us. The other things that we do are we do fairs, where we would involve, where we would reach out to homeless people, go out to them, invite them for a hot meal, for haircuts, things like that, and also support with access, with language. We've got a few of our team members as well that actually go around to hostels and meet with those people.
If you could see a little bit of that we would appreciate.
Yeah, we are on day 24, but we will get to that.
Yes. Nikki.
Can I just do a bit of a reality check here? So what we're talking about is a registered list, and it's great that we've got, as Adil said, NHS provider, NHS the trust, but we have, and fortunately I've got Jill in front of me, we have a Luton Place board, so we will work collaboratively because we can't do in isolation to a practice. So there is a whole raft of work with the community voluntary sector, but what is brilliant is that we've got an exemplar practice to do the role modelling, and that's for me where we're coming to. So any patient can register with any practice in Luton. You do not need to have an address. Now, we have a bespoke homeless enhanced service. So basically some of the practices, I know Lee Vale, and I can't think of the other one, I don't want to give you the wrong name, but actually have those staff are skilled to really understand the needs. The reason it's quite useful, the Lee Vale practice, because they work very, very closely with NOAA and a number of the community voluntary sectors. So absolutely, it's brilliant, because I say you'll be role models, but I just think, no disrespect, buses and stuff like that are a cost, and I can't imagine that's not commissioned. I don't want people leaving this room thinking there's going to be an amazing thing with this contract. Just reality check.
Pat.
Sorry, I've got a few questions. Sounds good, but how will this service be monitored? Because there is a bit of a postcode lottery across Luton with the standard of services.
We're going to have a system of internal monitoring, and also we are monitored by the CQC as well. The CQC have already done a primary check on Elft, and that's why they were given the go-ahead, and we'll have a formal CQC inspection in a few months' time as well.
Yeah. If you in your paper you say that you've got obviously Elft's mental health services, will you be prioritising your patients above other patients in Luton? Because that's the impression it reads when you read the document. Yeah.
Not at all. I think basically with Elft's expertise in these fields, okay, not only can our patients gain better access to mental health services, but hopefully what Elft will be able to do is help other practices in Luton as well. I think what Elft want to do is not only work with our practice, but they want to work with Luton in general.
The general direction of travel, you know, for us this is quite new, but Elft seem to have been doing quite a lot. Will it mean that in the future, this is probably not your question, it's probably Nikki's question, is this the direction of travel that we will go this way in the future?
So just picking up the point, in the primary care strategy that's part of the ICB, we didn't want to, we were very clear that list sizes of less than 10,000, we wouldn't go out to procurement, because when I arrived in Luton, there was some practices that were 2,500. It really isn't a resilient model. And that was why Kingsway and Birmingham have been put as one provider. So there is a procurement process. It is a very transparent. I personally don't get involved in the actual details of it. Otherwise, there'll be a conflict when you're doing the strategic role. So East London Foundation Trust were the successful bidder, and that comes with a whole raft of what the criteria were. Now we've got East London Foundation Trust provide a practice in Bedford Borough and one in Central Bedfordshire, and in fact, what the opportunity is that East London Foundation Trust are part of the Bedfordshire Care Alliance, and David's over there from the Acute Trust that's part of that and leads that alliance. So it does give that opportunity for more collaboration. Now, for me, it's we don't want this concept of referrals is about passing patients around the system. So if you can get your practices helping to manage conditions, a higher acuity level, one would hope that your referrals and the traditional words will become less. But equally, it's about shared working and learning. So we are, and in fact, in this very room, a few of us were in here last week of the Health and Wellbeing Board about this integrated neighbourhood working. So by having this practice and ELF being the mental health provider and being part of the Bedfordshire Care Alliance with Cambridge Community Services, it gives a really good opportunity in the PCN area to do that neighbourhood approach. But I do stress the acute trust are part of that community voluntary sector. It is about community development, and I am thrilled. Yeah.
Are they in the same PCN? I don't know that. Yeah.
So they fortunately are. Had they not been, would have amended it. So there is Phoenix Sunrises of the PCN, and as my colleagues are saying, they're only 24 days in. So it is about, we need to make sure we're aligned with the priorities of the Luton. So the Luton Place Board have priorities, and interestingly, primary care access is one of them. So it is about making sure that the practices, the PCNs are all aligning, so we've got one common purpose, because it's that systems working.
Councillor Ali. Councillor Hussain.
First of all, I don't know, for some reason everybody else has got this paper except me. I've just come in and just read it. Item 7, I didn't have it, so I just read it while you were doing your presentation. In terms of the ELF, I mean, the ELF is specialty in mental health, and you have been providing services for Luton as well in the past, or continue to do so as well. But is that, the Kingsway and the Birmingham, is that the idea is to be for the patients to have a easier access to the services, or is it making it, you can get a GP appointment in this lifetime, you're a lucky person, you can get to the moon first before you get a GP appointment. So if it was legal, I'm sure Nina Pearson would have a right go at me. But that is the reality of life. So what are we getting in this new, what you're presenting to us today?
Thank you for that. I think we're dealing with a lot of problems here with regards reality and perception as well, and they're two different things entirely. A lot of people have the perception that, it's impossible to get in to see a GP, but I'm seeing patients every single day. I see more patients than I should be seeing every single day, especially now post-COVID than I did before. Access is an issue. ELF have not come into primary care solely for the purpose of improving mental health facilities. That's not the reason why they've come into primary care. That is a feather in their cap, definitely, but that's not the primary reason, and that's borne out by the fact that they do provide primary care services in other areas as well. Access is, as I said before, is one of the biggest issues that we are dealing with, and this has been set out in government strategies. The main priorities for the next few years is for all of us to improve our access in various ways. So this is something it's a nationwide problem. This is something we all have to sit about. We have to look to see what we can do, because at the end of the day, all the resources we have are finite. They are finite. And we need to see how we can use those resources and actually develop new ways and new strategies of using those resources without leaving the vulnerable behind as well, because that's very, very, very important. That's very, very important. And I think that's an emphasis which ELF makes, which a lot of people, other organisations don't focus on.
I'm not suggesting you don't see any patients. All I'm suggesting is is that, from one's own practical experience, an average phone call that I make, right, or do an email takes about 45 minutes for me to get an answer on a phone call. So that is an average, I'm saying to you. I could have 3 cups of coffee or probably walk, get to London, and then the phone would be answered. So that is a reality of life, people that are living in the real world. So yes, GPs do see patients. I have never, ever said that they don't. What I'm saying is people tell me, and my own experience, the people that have elected us tell me on the doorstep. One of the biggest problems they have is access, and to be able to, not only to see the GP, but to talk to a human being, rather than listening to that Sam tune for 45 minutes. So this is what I'm saying is that if we are, these things, I hope the ALF's previous track record in mental health is pretty good. I do remember that. But in this particular thing, I hope that this will improve services, or is it going to be what we got already in terms of that? Coming to primary care is, is that an improvement? That's all I'm asking for.
We always say we can't expect a different result if we keep doing the same thing. So again, to manage expectation, we have, again, in our, like Nikki has said, we have another practice in Leighton Buzzard and one in Bedford. What we've done there, we made some changes where we have a centralized back office function, and this is where we're talking about phone calls. We also have cloud telephony. This is not something that we want to immediately pass on to Kingsway and Birmingham, but this is something that we are trying to do things differently. So we have a back office function that actually caters for 2 surgeries, where we have a number of quality improvement projects, how to improve access, how long people stay on the phone, and this is something that is monitored on a weekly basis. We have reports, and this is something that is quite important. I know there's some anxieties with ALF being initially a mental health provider, but the assurance that I can provide is that we have different pillars now. We started as a mental health provider, then we moved into community health, and now we are, we want to do primary care. Like I said, we have services in London, now 3 in Bedfordshire as well. So I think what I'm trying to say is, we are trying to do things differently, and we will try and do things differently to improve exactly what you've just said. But this, it will take some time. Over the next couple of months, we will be working with Dr. Adil, with the practices, with the practice managers, to understand what their difficulties are, and also, try and implement different ways of working.
It's just worth mentioning today, the Department of Health and Social Care have launched a campaign. And that will be nationwide. And a lot of it is about the multidisciplinary team of primary care. A lot of our residents still think they have to see a GP. And we know that there's a lot of other members of the team. And that, I think, again, is this practice has the opportunity of role modelling, because it's probably got a bit more of the resource to actually help do that connectivity and with patient participation. But again, it doesn't always go down as well where people have really set their heart on seeing the GP. But evidence-based is a paramedic or a community pharmacist or a nurse will give person 100% of what they need. So again, I think that's what the 4 of us will have to be doing. And I know at the Health and Wellbeing Board, we're going to work with some councillors about really reshaping that message.
I mean, I'd love to see in 6 months' time if you come back and let us know how things are, because I'm myself not a Kingsway patient, but the services are, if we can make an improvement for the for the patients, that's what will, because we have a serious problems in terms of health in Luton. We seem to be leading on whether it's obesity, cardiovascular disease, diabetic, everything, you name it, we are well above the national average. So anything that can do to improve those things in terms of people in Luton would be welcome. So that's all I'm asking is that, from the previous experience and the primary care, if it can do better than what has been done in the past, would be a major welcome. So we would like to see you in 6 months' time, and then hear what the people's experience is.
Yeah. I've been at Kingsway for the last 13, nearly 14 years now. So I've actually been through 3 or 4 providers already. And what I've noticed with previous providers, they've come in with a one-size-fits-all policy, which I've always opposed. Because Luton itself is quite different from other areas. It's even different from inner city practices in East London. It is different. In my conversations with Elft, they have recognized that they cannot enforce a one-size-fits-all policy. We have to be proactive. We have to be reactive. We have to develop models in consultation with the community. And look, the models which we propose may not be the right ones, first of all, but it's very, very, very important that we do try, and we are constantly looking, analysing and reflecting and improving. As Nikki just stated, there are quite a few people who phone their GP surgery who don't require actually seeing a GP, but that's not what they think themselves. So it's very, very, very important that we have proper triage and we are able to channel patients to the appropriate services for their needs. And that's something we're developing with Elft and through our primary care networks as well, through health and well-being coaches, through social prescribers, etc., etc., etc. And, you know, these are all relatively new ideas. Patients don't always understand exactly what we're trying to do, but it's a question of working with our community and helping them and seeing them how to use the service to the best of their needs.
Thank you, Chair. Nikki does know my views, so I don't have to keep on about it. Thank you.
Councillor Ali, then Councillor Khan. Councillor Foy.
Thank you for your report. I personally think this is really positive. I think the premise of Elft as a non-profit organisation will definitely help. Actually, I don't know. I'm saying definitely. I have no idea. You're 24 days in, but I feel quite positive that this is going to be a good thing. And I also like that you mentioned, because Nikki's spoken a lot about cloud-based telephony, and I think Kingsway is a practice that really needs that. It's not my ward, but I get complaints about Kingsway in terms of access very often, and I live very far away from it. My dad is one of your patients, so I know that that's something that would be very, very beneficial to Kingsway and probably Birmingham Park too. I don't know anything about that. I'm just a bit confused in terms of, so the PCN, Phoenix Sunrises, so 2 of the practices within that PCN are going to be under Elft. There are, of course, other practices that are going to be part of that PCN. How does that work in terms of, because obviously what Elft will be doing will be different to what the others will do. Is that even relevant, or is it?
I'll just say, as a provider of primary medical services, they're a provider, so they have the contract, so it works in the same way. There won't be preferential treatment, and it's the same system processes. But what we have got is primary care networks and neighbourhood working, is that you've got, you could say, the right mindset in the sense of what we're trying to achieve. So already, I've not met Gemma before, but the transformation manager. So actually, what it should happen is that we've got some momentum to do change. And as you quite rightly say, if you keep doing the same thing. So I am hugely respectful to practices, and they tell me that they, can't cope and whatever. Well, we've got to have some different systems. So as an illustration, we've talked about same day access. is that we need to have a responsive service that if you ring the telephone, that it gets answered. If you walk into the practice, there's a receptionist who is trained up for care navigation, and you may not get a GP appointment by walking in, but you will have the clinical triage, and if it's you need to be seen, then you will be seen. So or if you've done the online, as some people do, is that there's that blend, that opportunity. But you're quite right, and we're very aware, because we've done some training of people who are deaf, training of people who've got no use of English language. So, you know, we've got to think of those other ways. And in fairness, that's what we have got with East London Foundation Trust. They've got a big engine behind them, call it a mothership, where they've got people who've done that inequalities and you know, what we explained about what you've done in Newham and Tower Hamlets is you've got learning from elsewhere. And my job is to basically make sure we spread that, not just to that practice population that's of Birmingham Kingsway, but how we get it into the PCN, and then we start showing good practice to that PCN to the others. And, you know, hopefully, you know, Jill's in front of me, hopefully we've got better connectivity with social care services, and we know that can be a gap. We know sometimes I have some awful instances where the GP practices haven't responded to maybe a letter from social care that are wanting an assessment on somebody for fostering or for, you know, whatever it is. So we hope we'll get that, and I'm not suggesting that every practice is bad, but is that we should get some systems and processes that are what I call responsive, and the rest of the system partners will say this is a pleasure of a practice to work with.
Okay, thanks. So it shouldn't basically affect anything. Okay. The other question I had was about the agenda for change, and how would that work, transitioning everyone onto agenda for change? Will that lead to job losses at all or anything like that? Because obviously the agenda for change is a one size fits all, and if you have people in your practice that are on higher than their specific banding and stuff, how does that work? And yeah, I'll let you answer.
I think this one is probably for me because I'll be leading the consultation to move staff over to agenda for change. So from the ELI data that we have received from the previous provider, we have a match against our banding. So far, everyone we've identified, there's no one who's going to be paid less. If anything, everyone will be paid more than what currently is. And also the terms and condition for agenda for change, as you know, we have the sickness, sick leave entitlement, annual leave, also the annual special leave. I think this is something that is being, as part of the informal conversation we've had with all staff so far, it's been well received. And I think people are quite impatient as well to move to agenda for change. So the process will be, we will be following a formal consultation with all staff, so that they understand the terms and condition, the date that it will be, the proposed date that they will be moving over to agenda for change, what it means, annual leave entitlement, sick pay entitlement, redundancy, all that kind of thing. As it stands, we haven't identified anyone that who will be that we think will do their job.
If anything, ELF has stated that they're going to be increasing the number of staff that we have employed in our surgery. As you stated, the GPs won't be on agenda for change, if I understand correctly, but all the other staff will be. And as I said, that we have plans to increase the staff on all. Be they nurses, be they admin staff, etc., etc., etc. One other thing I'd like to just state is that, as I said, I've worked with many providers, and as you may or may not know, providers work on a matrix. So what they have is, if you have X number of patients, this is. There is a equation which will tell you how many doctors or nurses you have for that set number. No organization has been open about this with us in the past. We've never known what the matrix is, and we've never been told if you get 1,000 more patients, do you get extra doctors? Do you get extra? We've never been told this in the past by any organization. But ELF have said that they will sit with us they're open with the matrix. They've showed us what the matrix is, and they will sit with us, and they will examine the matrix on a month-by-month basis. And if patient list sizes are increasing, which they are increasing, they will actually fulfill the promise of increasing clinical staff in parallel with that as well. And no other providers ever said that to us.
Okay, thank you. I think it would be useful, like Councillor Hussain said, if we could get a report back on the progress, because I'm interested to see if this works, and maybe other places can follow suit if it does work. Thank you.
Thank you. Councillor Khan?
Is it still on questions, or can I make a comment? Yeah.
Go ahead.
I think this is more of a point of order. I think that the presentation is positive. It makes very clear that they want to improve services. So whilst I respect and understand my colleagues' concerns, this is not a place for raising grievances. It's a place where we, hear the report and make comments on the report. So if we can keep it relevant, that would be great. Thank you.
Thank you. Councillor Fry.
Thank you, Chair. I think it's a very positive report. I just want to ask a couple of questions based on the amalgamation. Does that mean that Kingsway patients would be able to access Birmingham if there's services there, and vice versa?
Yes, they will be able to, and they'll be able to go through one central point of contact, and they'll be able to pick the options on the telephone call. We haven't recorded the exact message yet, so I won't promise which one's going to be which option, but they will be able to access services across both sites.
Fantastic. That means they actually get an increased service, don't they?
Yes.
Could I just say that's already occurred in the past? So a couple of months ago, our systems went down at Kingsway, and our patients were quite happy to come over and see me at Birmingham. So yes, this has happened in the past, and will happen in the future as well.
Thank you. And one other question. I just wanted to understand how you were going to remove the inequalities with the electronic e-system that you're bringing in.
So looking at the e-system at the moment, and obviously that is one area of access. What we've done in other areas and other our practices is we have projects where we work with our patients, and it's something that ELFT are really, really good at. Patients are involved in everything. And I've already spoken to the PPG already, and we've already started looking at what we can do around digital poverty and ensuring that we've got access for all of our population and trying to make it as fair as possible. As we say, we are on day 24, but we have already started those plans with the PPG, and hopefully when we come back in 6 months' time, we'll have a bit more of an update of where we've got with that.
Thank you.
Thank you. Any more questions? Okay, thank you very much. I agree with my colleagues. It's very interesting and promising developments, and I think yes, it would be good if you could come back in whatever is a sensible time frame to update us on progress and how it's going. Thank you very much. Okay, let's move on to item number 8, the L&D Hospital Helipad project. David, I believe.
Thank you. So I'll be quite brief in terms of the report, but just give a sort of history of where we've got to, and then perhaps I'm sure there'll be some questions. So just to first of all, a sort of big thank you to everyone who was involved in supporting the appeal over a number of years, and it's deeply disappointing that we've had to pause the appeal. So the appeal was raised. Oh, sure, no problem. Thank you. So just in terms of the sort of history, really, we raised the appeal, started the appeal back in 2016, and the appeal has been very well supported over the years. So the original plan was to link the ward block at the back of the emergency department. So anyone who knows the L&D site, we've got wards 10, 11, 12. The idea wasn't to put the helipad on top of that wall block. The idea was to build a lift shaft alongside the wall block, and but we would then have vertical connections between the wall block and the lift shaft with the helipad at the top. So we ran into some problems then, effectively back in 2021. So 2021, we were awarded around £17 million worth of capital for the redevelopment of the emergency department at Luton, and in fact that work is coming to a conclusion. We're not quite finished, but anyone who's been there recently will have seen the works and the new front entrance that's in place. That work has been really fantastic and a real advantage in the sense of we've managed to increase the accommodation within an ED. But as part of that work, we did more invasive testing of the infrastructure around the where the helipad was going to go, and original assumptions we'd made about the that the horizontal connections with the wall block would be strong enough were questioned by an independent report we received. And so effectively the conclusion of that report was that if we were to be able to proceed with the helipad, then we would have to decant the whole three wards, 10, 11, 12, and do some strengthening work. And that just is not a feasible option. So at that point, we had to take the disappointing decision that we had to pause the helipad project. Now, previous reports that we've had have indicated that that site is really the only site at the moment that we could put a helipad on the Luton Dunstable site. If we were to build in future in different parts of the site, there might be a possibility, but at the moment that was the only feasible option, and therefore we've had to say that it would not be right to carry on with the appeal at this point, and so we paused the appeal. The air ambulances will continue to operate on the site in relation to how they work now, which is the school field, which is then ambulances transport them to the emergency department. Once we made that decision back in March, we did communicate. We had a communication plan with all of our stakeholders that have been involved, and that involved the County Air Ambulance Trust, grant-giving trusts, the local mosques, MPs, and so on. We also have got a very useful frequently asked questions section on our charity website, and in fact the details of that are in the report. That is quite useful. It goes into some of the questions that we've been asked before. Now, the majority of the funding was donated by the County Air Ambulance Trust's Help Appeal, so that was the majority of the funding, and that's a national charity which raises funds for helipad developments, and that donation has been, and the pledge from them has been returned to them, because that's their sole interest, is the creation of helipads. In terms of local donations, we received about 460,000 from the community, all through local organisations or grant-giving organisations locally, but effectively from local people. And of that, about £100,000 has been allocated to other funds, and that includes, and that's in the report, so things like the Emergency Department Appeal, the Maternity Appeal, our Paediatric Emergency Department Appeal, and some of it allocated to our new robotic surgery, which is now up and running at Luton Dunstable. In relation to the balance of the funds, there's only a small amount of funds that have been returned to donors, but we've kept that open. If anyone wanted their donation returned, then we've been open to do that, but only so far a very small amount has been returned. Most people have been happy for that to be returned, allocated to our other funds. And at the moment, the balance is still in that position that we have a balance of 361,000, which we will allocate to other funds within the trust, unless any of those donors want to returned. So that's where we are now. It's deeply disappointing, and as I say, it's the support from our community has been fantastic, and it's just really disappointing that we got so far, but in the end we weren't able to build the helipad, and we therefore have wanted to use any funds we've collected in the best way that we possibly can, and to use it for the other appeals within the L&D. Perhaps I'll stop there and open up for questions.
Thank you. Councillor Hussain. Yeah.
First of all, thanks for coming here. But this was one of the things that this come from the community. That I mean, I wasn't even personally, but was not aware of it. But it was the thing that the community was very enthusiastic and gave very generously. I attended a number of the fundraising event where people have given very generously, and the incident that really brought it up was that young man. Had it been for the air ambulance, whose life would have been, and the hospital promised that they will make every effort whenever the opportunity arose to have this service of air ambulance, because he used to land in the park and then the school, as you're probably aware of it. So what I think people would want to know is that in the long, I mean, this is the most important thing in terms of life savings. And in that sense, are we going to see that this will be sometime in the future, as you are doing a lot of building work, that this facility has got any reality of having an air ambulance like some of the other hospitals have?
Yes. The Luton Dunstable is a difficult site, as you know, because it's constrained, and also we had the Civil Aviation Authority look at the site to see what would be possible, because there are certain restrictions, for example, in terms of where it could possibly go. So, for example, part of the site borders where we've got pylons, and that causes problems. There's all sorts of technical restrictions. The reality now is, if we want to rebuild a ward block on the L&D site, so 10, 11, 12, which are those wards, we've got other wards which need to be rebuilt. We don't have funding to do that, but if we were to build a new ward block, then we would look at it again. But unless we have that possibility, then it's very difficult on the L&D site as it currently stands, because of the restrictions on the site. So it remains an objective for the organisation, but it wouldn't be right to continue fundraising unless we've got an absolute cast iron way of delivering that at this point, and which at the moment we don't.
And the other thing, in terms of the growth in the population, and in terms of your areas now covers far greater than when it first started off. So really, and having the motorway right next to it. I mean, I myself sitting here today, wasn't for the air ambulance in some years ago, I wouldn't be here. It was from Chelmsford to Basildon, and it had to be, taken within a matter. And it was, so to me, it was a personally very personal thing to me, because the air ambulance that the service was given. So I think because of the where the hospital is, and the growth in the population and the area that it covers is considerable amount. So I would hope that this would be something that you would prioritize for the foreseeable future, because it is the most important thing in terms of somebody having a heart attack and to be able to be given a treatment immediately.
Yeah. Particularly grown, our catchment has become more dense effectively. So the number of patients that we see has become greater. Although obviously we've now merged with Bedford Hospital as well, so we've got an additional catchment. But our real catchment hasn't grown; it's just grown in population and become more dense. But as I said, we will look at any future developments on the site to see if it's a possibility in the future. I mean, it remains relatively small numbers. It always was and will be relatively small numbers of people who are transported through that route. But as you say, they are the ones who are in a particularly time-sensitive situation where speed is of the essence, and that was the reason we developed the idea in the first place. So it is disappointing, but we need to see whether we can get, and one of the things we want to do is redevelop the whole site by stages. I mean, at the moment we've developed the emergency department, the front entrance, but the main development on the L&D site is building a new maternity, neonatal and critical care unit, which is going up at the moment. So anyone who's been on the site will have seen the building works that's going on. But that's really only part of the rebuild of the Linton Dunstable. We want to try and get funding to rebuild the whole site, and there's many parts of it which do need rebuilding, but that depends on us getting increased funding, obviously, for capital. And as we know, there are many calls on capital at the moment, particularly in the east of England, where we have a number of RAC hospitals who've got RAC concrete. We don't have any RAC concrete on the site, but we do still need rebuilding to continue on the site once we've finished our current new block.
Okay, anyone? Councillor Gallagher.
Yeah, I just wanted to ask, this 361k that's left over, is the idea then is to allocate that money to other things that are going on in the hospital? So that
yes, that's the idea. So so we've given at the bottom of the report some of the other schemes that are on at the moment and where we'd reallocate that money. But if anyone still does come back and said they'd like it returned, then we do that. But otherwise, we'll allocate that to the additional funds.
sometime in the future for a helipad then?
No, I mean the Charities Commission doesn't like organisations to keep funds for in that way. So it would be inappropriate to keep those funds without a scheme on the stocks that was viable.
Thank you. Just to follow up on that question, so this decision, will that prejudice any future? Do you think that'll influence future donations or funding? Will people be less likely to give funding to a helipad project?
Well, I think it would be only right and fair to say that if we were to restart the helipad project, we'd want to be absolutely sure that it was part of a programme we could deliver. And I would expect that some individuals might be, if they've been involved before, would want that reassurance before they get involved again. Now, the L&D site is a very difficult site, and the emergency department scheme that's going on at the front entrance, the reason it's been delayed, and it's been delayed many times, is because we're developing old buildings and you find things and all sorts of things come out of the woodwork. It would be much more, it will be, if we were to build a new block, that's when it becomes more straightforward. So like the block at the moment, we cleared the site and we're building out from the ground, whereas the ED project is a refurbishment of existing buildings, which is much more problematic. So I think the answer to your question is yes. I think we would expect people to be slightly cautious, and we'd want to be absolutely certain before we restarted a fundraising project for helipad. But at the moment, it's difficult to see how we do that in the short to medium term.
Thank you. Just one other question about the process that talking about in paragraph 5. Is there a scenario where the helipad could have been built on top of an unsuitable ward block?
The problem with building it, so the ward block we're building is not next to the emergency department. So plus it would have compromised what would have gone into that ward block. So we didn't look at the time because we had an alternative scheme, but it's away from the emergency department. So what you really want is and what we'd like to do is to build a ward block which would then give immediate access. So the current block isn't, well, it certainly isn't now because we're in the middle of building the scheme, but we would have concluded it wasn't a viable option in that place either. Because the block we're building at the moment isn't actually a ward block, it's maternity on the ground floor. It does have wards for maternity, but it's not general wards. It's maternity, critical care, the neonatal unit, and some theatres, or quite a few theatres, in fact.
Okay. Thank you. I think this group shares your disappointment that we're not going to get a helipad in the near future. That. And hopefully it will be built at some point in the future. Thank you.
Thank you.
Okay, move on to item 9, vascular service development plans. And we have We don't have anyone to. Oh, sorry. I beg your pardon. Yes, would you like to introduce yourselves and carry on? Thank you.
Good evening. My name is Ben Gainsford. I'm the General Manager for Vascular Services, Orthopaedic Services and Urology Services for Bedfordshire Hospitals. And I'm joined with Mr. Nadeem Noor, who's our Clinical Director for Vascular Services. So we're going to do a slight double act on our presentation here. So I hope that's okay. And we'll also take the report as read. So I'll just give you a little bit of an overview and then leave some time for questions. So just a quick introduction about vascular services. So this is a very highly specialist surgical service that focuses on veins and arterial disease. And as it's highly specialised, it's actually arranged around networks. So the networks are around about 1 million population. And so you have one vascular team covering a whole network, and those are arranged in a hub and spoke. So for our area, we're in the Bedfordshire, Luton and Milton Keynes network, and with the hub currently being at Bedford Hospital, and then the spokes being at Luton Dunstable and at Milton Keynes. And the way it works is that sort of all of the high volume services happen at all three sites. So your outpatient clinics, your sort of minor day case procedures, most of the diagnostics, and also your ED attendances would go to the local hospital. But patients who need admitting overnight, so your major surgery, all of your both in terms of planned surgeries and unplanned emergency care would all be directed to the hub site. And that model's been in place for many years. So in terms of that major work, that hub only work across our network, we're talking around about 400 admissions per year. So it's not a massive service, but 400 admissions per year. And of that 400 admissions, we're talking about a quarter of those are from the Luton area. So about 100 admissions a year affecting Luton patients. And so the proposal is that we want to move the hub from Bedford Hospital to Luton and Dunstable Hospital. And that aligns both with the acute services block that David was just talking about. So our opportunity in terms of new theatres, and I'll let Nadeem talk a little bit more about the sort of technology and clinical aspects of that. But there is a need for upgrading a lot of our equipment and having equipment that we can't put in place. So it's not feasible for us to put in place at Bedford Hospital. And also we've now merged, as you're aware, with Bedford Hospital, so it makes that slightly easier corporately. So the proposal would be to move the hub from Bedford to Luton. We've gone through a number of steps already. So we've gone through the Clinical Senate, the East of England Clinical Senate, who have we had a detailed presentation with them. They were very happy with the proposal. We've gone through a number of public engagement events. Not all of them brilliantly attended, but we have held them both in person in all of the localities and a remote session as well. We've got a patient reference group, so we've been engaging with them. And we're going through the process of speaking to each of the health overview and scrutiny committees from each of the 4 boroughs affected. So I'll pass over to Nadeem to talk a little bit more about the benefits and the clinical model.
Thank you. So the vascular surgery has gone through tremendous change over the last 20 years. So hub and spoke model has existed between the Bedford and Luton for the last 22 years or so. But at that time, we had only 4 surgeons and we were doing general surgery as well. But over time, our workload has increased. The acuity of the disease has increased. Our population has increased and the disease pattern has changed and the demographic of the population has changed. So the workload has increased. So our numbers have increased from 4 to 7 and our population size has increased by the inclusion of Milton Keynes Hospital to 1 million. As I said, the vascular services, vascular surgery, I keep say surgery with a bit of inverted commas because we merge within the vascular surgery, the interventional services, the traditionally interventional radiology, the things that we do under X-ray control by wires and balloons and things like, and stents. That has merged with the open surgery. So now we require facilities which can accommodate both kind of technologies, you want to call them, in one place. And that is where the hybrid theater comes in. Hybrid means that we can change from doing vascular surgery, open surgery, to an interventional procedure, or sometimes we plan it beforehand. That is what we are going to do. Sometimes the need arises whilst we are operating. So that is where the acute block comes in. Then the Bedford Hospital, need to understand, is a small district general hospital. It caters for a very small population size, 250. All the support services are geared towards a smaller population size. The diagnostics, for example, the CT scans, MRI scans, things like that. Whereas the vascular based at Bedford Hospital has been suffering because of that, because the support structures weren't geared to supporting a population size of 1 million. So that's, as a clinical director, lead first, and as a clinical director, it has always been my kind of option to maybe at some stage move the services to Luton, which is a bigger hospital. It's more acute hospital. It caters for a bigger population size because it drains patients from the south as well as from the north and east and west part of it. So the merger gave us this opportunity to, and then development of the hot block gave us the opportunity to develop the services at Luton. For me and my team, the most exciting bit is not only the hybrid theatre and all that, but also that it allows us the opportunity to redesign the whole service from with a blank slate to start with. So there is the operating side is on one side, that expanded workforce is another, which will allow us to become more responsive. The hybrid theatre will give us more operating capacity. So we talked about the responsiveness of a service. We can, as I said earlier, that the acuity of the vascular disease has increased. So we need to, for example, treat patients within a set limits of time. So the vascular surgery is no longer an elective service. It's more of an urgent service. It is recognized throughout the country and the world that the vascular surgery is no longer an elective service. It's an urgent service. So we need to be more responsive to patients' needs, and that's an expanded workforce and the expanded capacity, and the hybrid theatre will allow us to do that. For other elements of the services, for example, the wards and the vascular labs and the clinics, we will repurpose some of the existing buildings, and there therefore are going to be some compromises. But we aim to build an integrated vascular unit where there is a co-location of services, the clinical accommodation, the consultant offices, the wards, the vascular lab, the gym. We want them to be co-located or be as near to each other as possible to improve the flow of patients. We are already talking to the patients to see what their needs are. We will be talking to other clinicians, the other services that are dependent on vascular, to see what they expect from us, both at the hub side and the spoke side. So we'll also be able to provide some additional services. So the technology of the hybrid theatre, expanded workforce, will allow us to develop new pathways. For example, limb salvage clinics, where there will be easy access or open access to the diagnostics and the clinical expertise for rapid decision making. So a podiatrist, for example, in the community may be able to refer a patient directly to that clinic. We may develop some deep vein service. We may develop pathways for patients who are at present referred elsewhere. We may be able to treat them locally. So there are several benefits. The hybrid theater itself also provides benefit for it increases the speed by which we can do a procedure. It reduces the radiation. So most of the procedures are done under X-ray control. So it reduces the radiation exposure to the patient and to the staff. So I will stop there because I can speak on that topic for a long time. I don't want to take your time. So I'll take your questions if you have any.
Thank you.
Sorry, I might be a bit dated, but didn't Harefields Hospital used to do a lot of heart surgery? Does that not happen anymore?
So vascular surgery relates to blood vessels outside the heart. So anything away from the heart is vascular surgery.
And what about funding? Will funding come like transfer? I know you're one hospital, but it must be allocated different funding. Will that come down with it? Obviously.
Yeah, so the funding model won't change. We'll be doing. The likelihood is we may well end up doing more activity than we were doing previously. As Nadine was explaining, there'll be work that currently goes further away that we would hopefully be able to repatriate, but that will come with the funding associated with that. So yes, the funding generally follows the patient.
There is investment though, so there investment in that. There's the workforce is expanding. That is investment. So the trust, the foundation trust, has invested quite a lot of money in developing the vascular services.
Yeah, please.
Can I ask you, in terms of for us to understand it more clearly, particularly to the people in Luton, are we saying that the Luton will be the main surgical side of the service? Yes, have I got that right? And Bedford would be for other tests and that. And would that mean that there'll be less people travelling to, say, Harefield or Pepworth or Addenbrooke's, and that everything will be done here? Because I'm thinking of, for people able to go to Addenbrooke's, it's not easy for the families to visit, and also for the patients to go for appointments and things of that nature. And similar goes for Harefield. So would we have a local facilities now for everything rather than traveling somewhere else?
You also to reiterate, the vascular surgery is different from heart surgery. For somebody who needs heart surgery, cardiac surgery, they will need to travel to Harefield or Pepworth. For vascular surgery, anything outside the heart, they will be managed locally in Luton. So as Ben mentioned, that the vascular services are organized in hub and spoke model. So the hub in general means that most of the inpatient work is done in the hub. So in practice, it means that all the arterial surgery is done at the hub, but the number of people who will have to travel to receive that treatment is a small proportion of people who will access the vascular services in general. They're mostly based on outpatient basis, and they will be provided locally. So Bedford Hospital will have 4 or 5 clinics in a week. The Milton Keynes Hospital will have similar numbers. There will be regular day case lists where they will have this minor surgery, varicose veins and things like that, and toes. In addition, the diagnostics will be done locally. So all that sort of the inpatients in Milton Keynes and Bedford, they will have access to a vascular surgeon almost every day, so that if there is a vascular problem that arises within the patients who are admitted in under any other specialty, medicine, for example, they will have access to a vascular opinion on the same day or the next day.
But one of the things that people are asking in terms of that, the specialist services, which will still need to go to other places, whereas these ones that you could probably wouldn't have to travel so much. I got that out. Thank you.
Councillor Ali, then Councillor Fry, Councillor Gallic.
Lots of questions. Thank you. This report is very good. It speaks a lot about the benefits. I just have a few questions about some of the challenges, some of which, if you've been at the other scrutiny areas, you might have already been asked. But so firstly, you said you've done some consultations in terms of access. So what have people said from other areas in terms of accessing Luton? So Bedfordshire, Milton Keynes, is that going to be a bit of an issue? What has been put in place to counteract any of the challenges that come from that if it's been moved to Luton? Obviously, I'm super happy it's moving to Luton. It's the best place to be. Secondly, how does it work in terms of staffing? So is it that the staff from Bedford are just going to be directly transferred onto Luton? Again, is that an issue in terms of where people work and live? Are they going to have to be, I know it's not that far, but things like that. And then finally, there's a little point about increasing surgery capacity for Bedford Hospital. And what does that mean for Luton? Will this increase the strain on Luton and the critical care beds? Or like if things go wrong and there's more people going into critical care and things like that, how does that work? Is that going to be an issue or no?
So the last question first. So the capacity wise, the vascular theatres being built at Luton are 2 new theatres. So it doesn't take anything away from Luton. It is, an additional capacity. We vacate some capacity at Bedford, and that will be used locally for the type of surgery which is in greater volume, so the greater need. The second question, staffing is a major kind of challenge which we are in the process of addressing. We are talking to current staff at Bedford, and they will have an opportunity either to come to Luton with us, or they will stay at Bedford and there will be another place for them. So nobody is going to be lose their job because of this move. That is an important thing to remember, because we're talking about nurses and they are like gold dust. We would want more of them, not less of them. So that is not an issue. We might need more nurses at Luton because we will have an additional ward at Luton, so there will be recruitment for that. As the medical staff, the consultant staff will move, the specialist nurses will move or cover in a wider area. So there are different kind of tiers of staff which we have already kind of planned for them. They are in the part of the whole project. We are not quite certain as to exactly what we are going to need when we move to Luton with regard to these staff, and therefore I'm not in a position to give you kind of exact answer to that, but that is on our minds, and is part of workforce is a big part of the project overall.
I just add one thing to that, which is that we've done some initial consultation with our staff especially this has been a conversation within the specialist vascular medical team for a while, but obviously there are a lot of other teams that interface with vascular and people who've got specialist skills, the theatre staff, the radiographers. They're all an integral part of the wider MDT. And we do acknowledge that not all of those are going to want to move from Bedford to Luton. So we really do have to think very carefully about, obviously we want to encourage as many of them who would like to move with the service, but we know the reality is that they will have reasons for wanting to stay local. They will have full opportunity to work, re-specialise with other teams. But we also need to make sure that we are training up and getting the skills up for the for any new staff that will be taking on those roles. But our whole kind of detailed workforce implementation plan, which will also involve a staff consultation, we didn't want to kick that all off before we'd spoken to all of the overview and scrutiny committees, because we felt that was a really important part that we needed to go through before we started unsettling all of our staff, because it is quite an any change is unsettling.
Yeah, just before that. So forgotten what I was going to say now. What was I going to say? So you're saying, so what's the timescale for this? Because you're saying that it's a whole new ward or 2 new wards. You might not be able to transfer all the staff over from wherever you are. And obviously there are workforce issues within the NHS already. What if we can't staff it well enough?
I mean, I think to a degree, so we've got until at least December 2025 until we're going to be going live. We aren't expecting staffing overall. We're going to expand the number of theatres. We are going to need more staff, and recruitment has been a challenge at times. But we also recognise what we are developing is something really exciting, and we're expecting people to really want to be part of it, because I think we can. It is a very exciting opportunity, and we actually see this as a way of addressing some of our recruitment difficulties that we've had, and particularly with difficult to reach groups such as interventional radiologists, which is a really difficult to attract group. But actually, by having some really good facilities, top of the range equipment, and importantly that the patient flows throughout have been thought through, so that one of the big stresses around clinical life is around when you've got patients who are not in the right place at the right time, creates delays or congestion, people are waiting, and that's all been thought through. So we're expecting it to be a really desirable environment and team to be working within.
So a lot of work has been done on this centralization agenda. So as I said, the hub and spoke model has been there for 22 years. The major reconfiguration of the vascular services took place in 2012 throughout the country. And the question that so the number of vascular centers were halved first, and now they are 1/3 of what the number was, say 20 years ago. So the one question that public was asked is, would they be able to, or would they accept a bit of a travel, maybe a 1-hour travel, to access state-of-the-art service, excellence in service? And majority of people opted for that. So our approach to the public at Bedford has been exactly that we are developing a service with the aim to serve their needs. And the fact that the number of people who will have to travel to Luton is a small fraction, a small proportion of those who will access the service overall. We also want to develop pathways where even when those who will have to travel will only travel when they are going to receive the treatment. So there are a few things that people need, for example, the investigations and the assessment, the anesthetic assessment, things like that. We will try and make sure that those elements of the treatment are actually provided locally, so that when they come, the only time they need to come to the hub is when they are going to have treatment. Another element, important point to remember, is that most of the elective, so-called elective kind of treatment for the, or I would say not elective, planned treatment is usually day case or overnight stay. So majority of the patients will, of those 120 patients that will travel from Bedford, they will be staying in the hospital for a very, very short time. Of those, the emergency services, who will stay longer, we will put in the repatriation pathways in place so that they can go to their local hospital as soon as after they are able to, and we will put the mechanisms in place locally for improving the therapy services, having the gym inside the ward environment or integrated unit, where we could improve their mobility, so that the length of stay is reduced. So what we are trying to say is that we will reduce their length of stay. We will repatriate them early to the local hospital, so that their experience overall is not as bad as they might fear.
Another question, just going on from what you said. So the recovery then, and the OT, PT, whatever you need post-surgery. So does moving over to Luton also include getting extra bits of that, or are you saying they're going to go to their local to recover? Or? So
most of our work is low limb work, so that their legs they ischemic, so they are unable to walk. So if we provide a better therapy service in the hub, their mobility will get better quicker, so they will be able to walk quicker, so they will be able to go home or to their local hospital quicker. There is certain elements of their getting better will require some social elements. They can't go home, but they are well enough, then they will go to local hospital for that elements of care. Does that make sense? No.
Councillor Fry.
Thank you, Chair. I think you've actually started to go some way answering the question I was going to ask, actually, because I was thinking about, you said earlier something about this tends to be more emergency care now. I'm assuming that's things like stroke, DVT. And I was thinking about what the education was, and I think what you're saying is the re-education of those people will be done at places like Bedford, away from Luton. Would I be correct in thinking that?
Right. Okay. So the patients are already involved in the design of the service. We have patient reference groups. We speak to them and we see what their needs are. At the moment, there is we give them patient leaflets, the clinical kind of talk to them in the clinic. We have specialist nurses nurses are always better in educating. Kind of they can talk somehow better at their level, and they understand each other. So we are expanding that tier of the workforce as well, so that more nurses can do that quality of life clinics and things like that. We want to do some work in the community, but our workforce at present, the 7 consultants, we are not enough to do that, but we are expanding the middle tier of workforce, and we are expanding the nurses workforce, so that will allow us, or may allow us, to do some work in the community, to go and speak in the primary care. Another element of our vascular services, the vascular AAA screening program, where we do ultrasound scans. The technicians go into the GP surgeries and they do ultrasound scans of the abdomen to see if the main artery in the abdomen is bigger than usual. They are trained to provide this quality of life advice and education to the people. There are other things that we can do. We are not doing at the moment. We can do time allowing is using technology better. To have some websites with the written and the video education things for people.
Thank you. I mean, I haven't worked in the NHS many years ago. I think this is a very good idea, and anything that can streamline, improve services is only going to have better outcomes for the patient at the end of the day. Thank you.
Thank you, Chair. My question was already answered with regards to staffing, so that's already been answered. The only thing that I would ask is if we could have something fed back to see how things are progressing and some point, a future date. Yeah.
I mean, the time scale will be good, so we can come back in 2 years' time, and we are you know, already here, or we can at some stage we can come earlier to say how things are going, whatever you like, really.
Yeah, whenever is a sensible timescale. I don't know what that would be, a year, 18 months, but yeah, whenever there's
18 months sounds like a good time frame for us to have embedded the service and delivered some of the service developments that we aspire to.
Okay, thank you. Just have the one question. You're talking about the service being up and running in December 25, by December 25. So I mean that's presumably. Is there any issues about the transition, that transition period from service as it is now to the service then? Is there any threats to the service that transition would provide?
I wouldn't say it's threats, but it is going to be a challenging process. We recognise it's, you know, moving the hub over is going to be challenging. We're going to do a lot of planning in the run up to it, and workforce is probably our biggest area of concern, and making sure that everyone that we have recruited and trained, and we've got all of that skill base. The reason for the time frame for December is that the acute services block is currently being built, and it's due to be commissioned, and services to start moving in earlier on in 2025. And there is a whole sequence of moves that need to happen, and spaces that need to be vacated. So the main one is making sure that we've got the space to be vacated in order to create the ward, the facility, not the theatre facility, but the outpatient and diagnostic and ward clinic outpatient clinic environment that we need. So that's why it's been sort of delayed to that position. But I think we're also, you know, anxious to be able to move as soon as we possibly can, because of all of the outcomes and improvements that we know that we're going to deliver through it, and we just don't, you know, any delay is frustrating. So, but there's a lot to do. So I think it's a realistic time frame.
Yeah, thank you very much for coming here tonight. It seems to be a very exciting development, and yeah, if you can come back in 18 months or whatever timescale is appropriate, that'd be great. Thank you. Okay, on to the final item on the agenda, draft work programme. So everyone, are we happy with the draft work programme as it stands? Any? I think the only issue I can see is that the meeting on the yeah, thank you. The 11th of January is very busy, so I think if we can perhaps do some reorganisation and rescheduling of some of those reports. If that's okay, then we can close the meeting. Thank you very much, everyone.